Here we are. I'm Joe Lamb, and this is Michael Stone, and we have coffee or tea. And I'd like it to be bourbon, but it isn't at this point.
Well, it's 5 p.m. somewhere, Joe.
That's true, but I'm on my way to the free clinic in a little bit, so probably contraindicated.
That is exactly true.
So Michael and I were talking about this today, and we thought we'd share this with you all. What does it mean when we hurt? You know, it's kind of a broader question. What does it mean to have any symptom? How do we figure out if a symptom is significant or if it's not? How do we figure out what a symptom is related to? And that's really of significance lately, because I don't know about you, Dr. Stone, but I had a patient who had hives and no good explanation for hives. And normally it would have been called idiopathic, but they had recently had their COVID vaccine, so it was said to be related. And it made me wonder about how many things happen at the same time but aren't related, but we assign causality to or cause to. And it makes me think about, the fact that I hurt when I wake up in the morning.
Well, those are good points. And I think it all depends on what lens the listener looks through and what lens we look through. When we ask ourselves or the practitioner asks that question. We all know that if you ask that question to a fellow worker who is doing the same thing that hurts, they said, oh, it's just, it's what we did. If we hurt and we haven't been around anybody and we're stumped and we're fearful about what it might be, we may come to different conclusions. If you go to a rheumatologist and you say you hurt, it's a different conclusion than a surgeon often, although it shouldn't be if we look through the lens of story, timeline, the constellation of symptoms, and acknowledge that, teach our tongue to say, I do not know, but let's find out.
Yeah.
So.
Oh, I cut you off.
No, it's really fine. I was just going to say, so what lens do we look through?
Yeah. Well, I have two responses to that. One is, I think one of the biggest gifts personally of going to med school is having all those years of experience to know what's serious and not when it comes to my own health. And so I consider that a blessing. And then your comment made me think of that paper that was done years ago where they presented complex history to practitioners in different specialties and asked them to make the diagnosis. And the diagnosis was dependent upon the specialty. So complex patient, lots of symptoms. Gastroenterologist called it irritable bowel. Rheumatologist called it chronic fatigue. The infectious disease doctor added in immunodeficiency. Psychologist added in anxiety or depression. The list went on and on about, everybody saw it in their own concept. The neurologist was like, well, do you have, kind of preclinical MS and blah, blah, blah. And, when we look at this, it's no surprise that patients get confounded about what their symptoms mean. And it's no surprise when they kind of turn to Dr. Google and come up with answers. Or maybe Yeah, go ahead.
Isn't that really true? Is that, I mean, I believe that that's one of the reasons that uh, biomarkers, not only that you can order many, but biomarkers have taken center stage and imaging has taken center stage for so many providers, right? It's not this Socratic, it's not the Uslerian approach that listen to the story and the patient will reveal the condition. It is our truncated history taking, recognizing that we can get tons of biomarkers and tons of imaging, and the answer is, well, I can tell you what you don't have, but it's not necessarily what we're looking for, and that's being replaced a little bit now even by layering in genomics. So I think it comes back to things that we've talked about all the time. How do we help the patient, help us understand the story that will provide the answer? Because as our lens through allopathia and the experience, we can already see sick, not sick. So then, meaning life-threatening, not life-threatening. So if it's not life-threatening, please tell me more of your story. Help me understand. You live with yourself 168 hours a week. Help me understand what has led up to this so we can begin to bring forward different opportunities to figure it out.
Absolutely. And I think that life-threatening versus not life-threatening is some of the aspects of that fit right into how do I decide as a patient what it means. So if I wake up tomorrow morning with a really, really, really severe headache, and it is just debilitating, and maybe even could be called the worst headache of my life, and really any symptom, like if it's new, if it's severe, if it's debilitating, it's a good reason to really dig in and look at it. Like it's a classic um, um, kind of descriptor. The person who says this is the worst headache in my life, we've all been taught to think subarachnoid hemorrhage, which is a little hemorrhage inside the arachnoid membrane that leads to bleeding and leads to compression of the brain and bad outcomes. And, we've been taught to, we've been taught that that's a crucial piece. And it's the severity that makes me want to go get seen.
That's right.
What other features would make you jump up in the morning and go see a doctor?
Well, I think one of the classic ones is new and unusual chest pain that you haven't had with the associated or a tearing chest pain. We think about, in allopathic medicine, we think anything that can cause sudden change in functioning of an organ. The heart attack, cutting off circulation, tearing at the major vessels of the artery, like of the aorta, like in a dissection. But you open this, Joe, with a very interesting question. How has a COVID vaccine with hives, the known unknowns, the rare knowns, how does that play a role in what we do? And I think that what we've also seen with neural inflammation with this virus is I have had a couple of patients say it's the worst headache of their life and it was unremitting. And it was associated with COVID. So you asked a very pertinent question. In a setting where we know it's not as easy to just waltz into the emergency room or not as easy to just waltz into an urgent care because of the infectious environment we're in. We have seen, and the statistics have borne it out, that people are waiting longer for evaluation, and thus things are going undiagnosed and unseen and untreated.
Yep. I had a telephone consult with someone this morning who fits exactly into that. They've been having new headaches, severe headaches, and they actually saw a doctor about it at the tail end of last week, and they felt that maybe it was all the patient did, particularly not the doctor so much, but the patient felt that maybe it was all related to their COVID vaccine. Interestingly, they broke out with a facial rash today, and they have herpes zoster ophthalmicus. So reactivation of the chickenpox chickenpox virus affecting the eye. And they had high intraocular pressures when they were checked out by ophthalmology. That's kind of one of those other things about, warning signs. If you have a rash with some sort of associated symptom, like if you have a new onset rash with a fever, or if you have a new onset rash and you have pain, those are also medical emergencies.
Absolutely true, especially discolored rashes. The classic, of course, Joe, is the fever in the young child with a purplish rash. That's a crying baby with fever, purplish rash. It's Neisseria meningitis until proven otherwise, right?
Right.
And so those become emergencies that you have
Right.
to respond to, right?
Yeah.
But I think you said another important thing, Joe, is if you have a symptom and a related dysfunction, the worst headache of your life, you may have visual changes. You also may have balance changes. You may have limb changes where you can't move things. You're not as coordinated. So it is symptom with related dysfunction is enough for me over all these years as an ER physician and a family doc in very remote areas and urban areas. That's kind of the constellation. It is brand new symptom with loss of function.
Yep. Another good one is one-sided.
Absolutely.
If you've got swelling in one leg and not the other, if you did something like, I weightlifted yesterday, I did some work, and I started getting discomfort kind of vague in just one arm or the other, but not both, but there was no specific injury, those are things to make you worry.
No, that's right. And with children, children are very smart. They don't use something that hurts. And so if your child is fine, they have a fever and suddenly they won't put weight on their leg, then it is absolutely worth, or they're not using a limb, it is absolutely worth checking out. It's not just because what we know, and Joe, you've seen this, our understanding of membranes and intestines, we know that bacteria can translocate, right? It can cross membranes and it can distantly spread. And so our appreciation of that is true whether it's bacteria leaving the mouth through dentition issues and triggering inflammation vessels and heart issues, or whether it's after a gastrointestinal infection, you have bacteria that cross into the bloodstream, and you end up with seeding of joints or seeding of skin. So you're exactly right. I mean, it's unilaterality on one side. It's associated dysfunction, and then you enter the whole aspect of new case. Even just today, a new butterfly rash on the mid face and the forehead, and some joint discomfort. So that brings us to the great masquerading of autoimmune disease. Huh?
Absolutely. Absolutely. And, I think one of the important take homes is things that come on slowly can still be severe and should be evaluated, but you also have more time to work on them. Things that come on quickly, you don't have the time to work on them. Like, as you said, the rash that's finally presenting in the setting of some other skin changes, the rash across, like the cheeks in the setting of some other skin changes. Well, and there's been some joint pain on and off. You got a little bit of time there. But, the rash that comes on today with the fever today, you don't have that time to do it.
And tying into what we've been going, what the world and our country has been going through. You can have asymptomatic or low symptom COVID, but if on day 8 you start having more shortness of breath, and it takes you longer to walk to your car, and you start having a cascading of symptoms, then we know you need to have that checked out.
Yeah,
and that's just what we have to do.
Right. Absolutely. And and things also, the other part about it is things that you can't ameliorate. If you have some aches and pains and you can take 2 Tylenol or 2 ibuprofen and it gets some better or a good bit better, you have a little bit more time than if you have a red hot inflamed joint and you don't get better. I would say if you know a cause, then you've got more clarity. But for most of us, knowing a cause, it's really hard to decide what that cause is. I spoke with a patient earlier today who thought she had amyloidosis. And it's not outside the realm of possibilities, but it's certainly not most likely. But it could have detracted from her following up out of her fear or out of anxieties about what we were or weren't missing in the evaluation.
Yeah, and then we come into what is the fear associated with the symptom, and the history. So somebody, we know this is true, that if I were to have a brother or a father who had chest pain, heart attack, and sudden cardiac death, then I'm more likely with reflux and chest pressure to go to the emergency room for evaluation for my heart at a higher frequency in the first month or 2 after that. And so that's also a good question to ask ourselves and ask folks that we're seeing is, what are you most frightened of? What is the thing that concerns you most?
Yeah.
Because if the sudden headache is a terrible headache, I'm worried that I'm having a stroke, and why is that? And one other question, why is that? Well, my my dear aunt just died of a stroke. Um, you know, I think it's important to ask the questions around the symptoms of what are you most concerned about, because then as a provider and as a listener, we can put it in the context of the fear. You know?
Absolutely. And, and I think that even goes for us as practitioners and not just as patients. Things that we've seen, they help us remember. William Osler, who you referred to earlier, Sir William Osler, turn of the 1800s into the 1900s, had a lot to do with medicine, had a famous quote about when you hear hoofbeats, think horses. But his caveat to that was, if you never think of a zebra, you'll never see one. If we've been fortunate enough to have seen a zebra along the way, we're much more likely to be able to diagnose it in someone now versus someone who's never seen that zebra.
That's exactly true. And if in Africa you hear hoofbeats, you often think of zebras, don't think of Appaloosas or Mustangs. So it's context, right?
Absolutely. And, speaking of context, when you talked about fear, the way most of us pick what we want to do in medicine, a lot has to do with what rotation we really, really enjoyed, right? Did we like surgery? Did we like peds? What were the attendings like? Sometimes it's just like, do I find that woman a great role model or that man a great role model? Do I want to be like them when I grow up, right? Grow up as a physician. We're all in our 20s and maybe even into our 30s when we're in residency and med school. But, it's a matter of how do I want to show up in the world? And, if you really enjoyed your experience on a rotation, it plays a role in how we choose the next one. But I think the flip side of that is, particularly for me when it came to internal medicine and, in internal medicine, you've picked that as a specialty, but then there's that whole world of subspecialties. And, which one do you want to pick? And I think what starts influencing that a little bit is I think very few physicians pick a specialty where they'd be afraid of dying that way. I'm not afraid of having a heart attack, but for whatever reason, coughing and coughing and coughing and coughing up a lung, whether it be like a lung cancer, and maybe that's because my grandfather had lung cancer, but, whether it be lung cancer or COPD or whatever it would be, I find that a really scary way to die. And I never felt as comfortable with patients dying that way.
That's a very interesting point, and that fear translates. We have the advantage that we've seen. I stopped counting after 50,000 patient encounters in my career, and we've had the opportunity to have glimpses into 50,000 different stories, and we've been able to put it in the construct of, am I fearful of that or not? For the person who's not in medicine, there is a whole story and focus when you see your favorite family member pass unexpectedly, or you watch the slow decline and transitioning to death in a family member with cancer, or you have a brother or a sister who had a severe condition that wasn't healed. The amount of fear and concern and anxiety and wrestling with humanity comes from a different place, but not necessarily a separate place than it does for clinicians.
Yeah. Oh, absolutely not. I mean, at the end of the day, clinicians are people we're no different than the person sitting on the other side of the table. We're all on our own journeys. We just have had the benefit of a little bit more training, but when it comes to dealing with business matters, we need to go to business people. When we do other things, we need to go to another source and figure it out. And we need information sometimes too. I think it was really funny. Do you remember Andy Rooney on 60 Minutes?
Oh yeah, sure.
Did you ever see that little piece he did on why doctors should never talk about sports or politics or religion with their patients?
No.
He basically said,
No.
the moment you talk about any of those three things, sports, politics, or religion, your patients will realize how stupid you are and they'll lose all trust.
There you go. I just know that the purveyor of pills should not necessarily be the purveyor of politics.
Yeah.
And vice versa.
Yes.
In honor of the anniversary of, maybe we could put some disinfectant in our veins.
Which anniversary?
It's the first anniversary of that highlight in treating the pandemic by potentially putting some disinfectant in our veins.
Oh, okay.
Yeah.
Yes. Okay. No,
sorry to derail you there.
No, I thought you were making some reference.
I mix politics and pills. It just totally threw us off.
When you were saying disinfectant in our veins, my thought was going to Scotch.
Okay.
In which one to partake of at the end of the day. So we're coming up on the witching hour of 4:30. Some of you all may have joined us Saturday morning. We had 90 minutes of recreation and visioning. It was Michael and I and Susan Buell and Courtney Suter, and we had a really powerful 90 minutes. Some very practical things about how to view your life and how to view your journey in health. 2 practical exercises were brought up as part of that. And that is archived here on Facebook Live. So go look at it. It was a foretaste of what we're going to be doing at Harmony Hill, June 11th through 13th, and at Feathered Pipe Ranch, the 5th through the 10th of July. We will be doing another Saturday morning. We haven't figured out what the agenda is. We haven't figured out what the team is for that morning, but it's all going to be part of our teaching team here at the Consilience Partnership. And it's going to be the 15th in the morning. So we'll have a program for you. And at that one, we're going to make a special announcement about our Feathered Pipe retreat. So look for that. And we'll be back not next Monday. We're going to take a break next Monday. I'll be on a plane. So we'll be taking a break next Monday. We'll be back the Monday after that. And Dr. Stone's in his office in Ashland, Oregon. I'm in my office in Gig Harbor, Washington. And we also have started recently here in Gig Harbor a series on cardiovascular health, GI health, and women's health. And the first couple in each of those series is also archived here recently, and you'll find the little titles and help yourself to some of that information while we take our holiday next week. We really hope to see you either at Harmony Hill or Feathered Pipe Ranch in person this summer, and we wish you well.